a easy standard paper. We are not expecting the INI-CET paper to be so easy. So today I will start with this INI-CET, you can say recall, because again when we talk about the upcoming exam, we get to know the mood. So it's very important for us to understand the INI-CET related questions and what could be the probable questions that could be asked in the upcoming exams. So if you have given INI-CET, it's already passed, so you don't panic about. If you have done it good, it's good. Otherwise, just take it as a practice test. So this time we had questions from GIT also, from thyroid also, from breast also, from urology also. General surgery, yeah, trauma was there, but not too many questions, unlike the standard. You know, INI-CET already we have seen that we don't get a lot of questions. Last to last it was 10, then it was 7 questions. And this year we have got a decent 17 questions have been asked. So let us start from them and let us start the discussion. I have already mentioned what is the topic, what is the subtopic. So PDF will be available to you after the class, and I will be discussing what could we. Okay, so what is not a marker of GIST? This is a straightforward question. So you know the GIST, they are associated with c-KIT mutation, and when they are associated with c-KIT mutation, this is a standard, you can say, marker for them. Then one more very important marker that we have is the platelet derived growth factor alpha. This is again very simple, straightforward marker, platelet derived growth factor alpha. Whenever you can say start this topic, I always start with the markers of the GIST, and I tell that the GIST which arises with them, they are the traditional GIST. If the c-KIT mutation is not there, remember, if c-KIT is not there or platelet derived growth factor alpha mutation is not there, then that will be known as a wild GIST. And when we talk about wild GIST, what are the markers for wild GIST? You all know that we have the BRAF, then we have the galectin 3, Wilms tumor 1, WT1 gene. So these are the standard, you can say, markers for the wild GIST. Then what about this succinyl dehydrogenase? Now when we talk about succinyl dehydrogenase, this is something associated with the familial GIST. And when we talk about familial GIST plus paragangliomas, now this condition, this is known as Carnes-Stratikis syndrome. So when we talk about Carnes-Stratikis syndrome, this is the variety which is positive there. So this is what is very important, that Carnes-Stratikis syndrome may SDH, succinyl dehydrogenase type B, is present. So this is also a marker. Apart from that, we have Dodge. So ये question NEET-PG में भी बहुत बार पूछा गया. It can be again asked. But remember, this is NRG1 is not a marker for GIST. Let us go to the next question. Now this is again a ritual. Earlier you used to get a question in every exam about GCS. Recent we have seen one question on EDH, SDH will be there. So first of all, even if you don't read the question, let us read the question. 25-year-old patient, you can say, presents to trauma post RTA in unconscious state with the following CT presentation. The moment you see the CT presentation, what are you getting this? You are getting this biconvex shadow, and this is a case of EDH. So EDH with loss of consciousness. Now this patient is unconscious right now, so probably the GCS is going to be low. Remember, if the GCS is not more than 8 and if the clot thickness is more than 1.5, and along with that we have certain other important things like the volume. If the volume is more than 30 cc, you will have to go for surgery. SDH in comparison to EDH is managed in a different way. Lekin EDH is considered as a surgical emergency. So whenever we have a patient of EDH, yes, you will have to go for surgery. And what is the surgery? We have to go for craniectomy. और अगर ये ऑप्शन में नहीं दिए तो that's the same thing, that is craniotomy. So abhi we were discussing like what could be a potential one more question coming from this. So we need to understand that every year we have a mood. So this year again we may get a question on this, and if you get a question on EDH versus SDH, what is the next thing that we get to see? So students, when we talk about EDH, there could be a question. Yes, the first line management is surgery. Everyone knows that it is the craniectomy. But what are the indications for conservative management? So if this question is asked again in the, you can say, exam, taking the upcoming NEET-PG. So if this question is asked, what are the indications for conservative management? Yes, you can do a conservative management if three conditions are fulfilled. What is that? If the GCS of the patient is more than 8, along with that the clot thickness is less than 1.5 centimeter, and along with that the clot volume is less than 30 cc. If all these three things are satisfied, yes, you can go for conservative management. So EDS पे अगर दोबारा question आता है, so this is a very popular question. Yeah. So here one question said about unequal pupil too. You can understand if the pupil response is, देखो these are the recall questions. So I have not given the exam. Niharika, if you can help me with the more proper refined options, yes, it would be great. I have just collected this from you people only. Even though if the pupil is, you can say, having an altered condition like Hutchinson's pupil is there. So these are the signs of developing neurological deficit. So EDH in a patient with neurological deficit, the management is not going to change. It is going to be the surgery. Next is, you got a question. This was a straightforward question. I hope most of you must have marked it right. So patient complains of dysphagia, regurgitation and weight loss. So when we talk about any problem, like lot of people start yelling, this is a classical triad of eclasia, this and that. It's a useless thing. Esophageal disorders are diagnosed on manometry, upper GI endoscopy and a combination of other investigation that includes the barium as well as the 24 pH monitoring. So any problem, even if you have a cancer in the, you can say, esophagus, again you will have the same problem of dysphagia, regurgitation, along with that weight loss. बच्चे NEET PG, just see, try to understand the mood. Last year Chicago 2 was, last year Chicago 2 was asked in INI-CET. Then last year also there was a question on eclasia. Again there is a question on eclasia. So there is always a mood of examiner or the trend. कहते हैं trend चल रहा है, like बद्दो बद्दी and lota lota, that singer trend is going on. So same way this is the trend. So whenever you have such kind of presentation, you need to understand, am I provided with something other in the am I provided with some other significant information in the question? Yes, if you see the barium image, now you can see a classical smooth tapering. So don't say that CA esophagus can also present with this, eclasia can also present with this, and even rare cases of early cases of diffuse esophageal spasm can also present with this. But even the Zenker's diverticulum could also present with this, that it is intermittent dysphagia with halitosis. However, if only this much of information is given, you cannot comment on the diagnosis. But if you see barium, there is smooth tapering. This is what is very important. Since there is smooth tapering, the CA esophagus has been ruled out. There is no pouches, so no pouching. So if there is no pouching, Zenker's is ruled out. And in case of diffuse esophageal spasm, it is a spastic condition, and if it is a spastic condition, you would get something like this. What is this? This is a corkscrew esophagus, and here you get a classical bird beak appearance. So this classical bird beak appearance, this is helping you diagnose a condition of eclasia. This is what is very, very, very important. Go to my lectures. Find them every time I discuss this topic in great depth and detail. So बच्चे, eclasia is a very, very, very important topic for your exams. And let us have a just one, you can say, hint. Okay sir, अगर इससे अच्छा question eclasia पे आया, so what could be the question in eclasia? Students, eclasia is a manometric diagnosis. It is very, very, very important. जो भी लोग कहते हैं, जो भी faculties ये कहते हैं कि eclasia is a what, is a triad diagnosed by the classical triad, उनसे कहना patient देखा है कभी नहीं ना, they don't practice, वो सिर्फ teaching करते हैं. And when you keep on teaching and you don't see the patients, you will lose the clinical touch and the importance of the clinical scenario around you. So बच्चे वो उल्टी सीधी चीज़ें पढ़ाते हैं और आप पढ़ रहे हो, वो मामू बना रहे हैं, आप मामू बन रहे हो. Remember, eclasia is a very important topic for your exams. Try to understand what happens in eclasia, and if you remember this, you will not even have to mug up anything. So whenever we talk about eclasia, you need to understand there is progressive loss of Meissner's and Meinrich plexus. So when we talk about progressive loss of inhibitory ganglions, बच्चे अगर inhibitory ganglions are lost, therefore the relaxation part of the esophagus will be lost. Are you getting this point or no? And then you have dysfunctional NOS. When we talk about NOS, that is nitrous oxide synthetase. So definitely the GE junction will be at a higher tone, and the first thing that you get on manometry, this is what is really very important. So on manometry, the first thing that you get to see, that is there is increased tone of LES. भाई हो सकता है there is increased tone of LES, but then since there is loss of inhibitory ganglions, there is no one to oppose the acetylcholine. यही तो सारी चीजें इंपॉर्टेंट है, and therefore there is progressive spasm of the esophagus which starts from the lower end. So increased tone. The second thing is failure to relax. The third thing is there is aperistalsis. Why there is aperistalsis? Because बच्चे, the peristalsis is generated because of a combination of inhibitory and excitatory ganglions. Aperistalsis is there. Then there is low amplitude waves. The amplitude of the waves is low. And the last is, in the late stage, the esophagus is completely collapsed. बच्चे, acetylcholine is causing the collapse, and this is going to cause pressurization of esophagus. And remember, you can just try to refresh. I don't think that there is any problem at my end. Maybe the internet is lagging at your side, because I am myself using this. I've logged on one of our set, so you can just try to refresh it. So pressurization of the esophagus, aperistalsis, low amplitude, loss of, you can say, failure to relax, and increased tone, and this is the criteria for diagnosis of, you can say, eclasia. So what is the criteria for diagnosis? It is very important that eclasia is a manometric diagnosis. So increased tone, failure to relax, aperistalsis, low amplitude wave, and pressurization of the esophagus. So those who are I've seen lot of faculties giving lot of solutions, but बहुत सारे लोगों ने ये कह दिया कि this is a classical triad of eclasia. बच्चे, eclasia किसी triad वेट से diagnosis नहीं होती. अगर आप triad diagnosis कर रहे हो, then you are not a surgeon, you are a homeopathic doctor. So आज की डेट में we have a good radiological support, a good evidence of investigation tools which will help us. So you know this. Now we get a question that a patient presenting to you with penetrating thoracic trauma with the following image. So whenever we talk about penetrating thoracic trauma, you know that there could be pleural injury, there could be pericardial injury, and there could be diaphragmatic injury. Majority of the patients of diaphragmatic injury are, you can say, asymptomatic. However, let us try to understand what could be the classical presentation. Had it been a pericardial injury, you had got a clear lung shadow. But you can see this is air, and here this is air. Rest, what is there? So there is haziness. It is not absolutely, you can say, fibrotic, something like a tumor, but after trauma, if you are having this much of haziness with the air fluid level, this is the most common diagnosis of hemothorax. But see, this is what is very important. Again, by this question, we need to understand what is the mood of the 2024 exams. अगर हेमोथोरिक्स पे क्वेश्चन आया या ट्रॉमेटिक थोरेसिक इंजरी पे क्वेश्चन आया है, yes, you can expect more important questions. What is that? So if you get a question, if I were to make a question, someone said, sir, this is a trend now, moi moi is a trend, make a reel on moi moi, है ना? So what I would have asked in case of this hemothorax, remember, I would have asked what is the criteria for massive hemothorax. This is again important. Let us revise it for upcoming NEET-PG exams. So when we talk about massive hemothorax, what is concept of massive hemothorax? More than 1500 ml blood. So more than 1500 ml blood into the thorax in case of adults. This is what. However, in kids, this is not the scenario. More than 25 to 30% of blood volume, more than 25 to 30% of blood volume in case of kids. This is what is massive hemothorax. बच्चे if I were to make a question, someone said sir this is an old outdated question, कुछ और अच्छा बना दो. बच्चे if you see the last NEET-PG question, there was a question on this. So in case of you can say hemothorax, pneumothorax, what is the management? Intercostal chest drain insertion. Yeah, you know, so that is what is known as tube thoracostomy. Now my question is there any indication to do a thoracotomy? So what are the indications for thoracotomy? So अगर question आया, so question इस पे आएगा, indication of thoracotomy for hemothorax. We all know that we do thoracostomy. This is what is very important, very important. So what are the indication? First is, sir, if it is a patient of massive hemothorax, thoracotomy has to be done because it is bleeding in a huge volume and patient can collapse. The second is, sir, हो सकता है कि you have done a thorax, you can say you have inserted a drain into the thorax and the volume which comes out, it's of paramount importance. So जो volume बाहर आती है, that is what is known as initial chest drain output. So remember, initial drain output more than 1000 ml in case of penetrating injury. Definitely if it is penetrating injury, it is more neat and clean, and more than 1000 ml means something vital is bleeding, or more than 1500 ml in case of what trauma, students? Blunt trauma. This is obviously qualifying for massive hemothorax. So suppose you miscalculated or you were not knowing, you inserted a chest drain and 1600 ml came out. You have to do. The third is, suppose you did a chest, you can say intercostal drain insertion. The volume which came out was 300. What to do? Again monitor for next 1 hour. Again subsequent 1 hour. So drain output, this is what is very important. So drain output more than 200 ml. This, the last year's question was based on this point. So drain output more than 200 ml per hour for at least 3 consecutive hours. But this is significant and it means something vital is bleeding, and this is an indication for thoracotomy. So agar isse, if we see the mood and we see ki bhai kya exact question aa sakta hai, this is a very close question concept which can be asked. The fourth is a case of caked hemothorax. So when we talk about caked hemothorax, what do you mean by caked hemothorax? Clotted hemothorax. If someone has to ask a very good question, what is clotted hemothorax and when will you say that the blood has been clotted? Imagine this is a thorax and this is the blood. So when you insert the first drain, if nothing comes out, you may think that I have not placed the drain properly and you insert one more. If 2 drains fail to evacuate the thorax, this is what is considered to be a caked hemothorax. Students, I am not boasting about my strike rate because genius people keep on commenting that okay, this is my strike rate, this is my strike rate, these are the questions. Legends don't talk about this. If you are a surgery dada, you can say the patron, if you are a surgery dada student, you yourself know that all the questions were covered in my notes word to word, all the questions. So I don't have to boast about this thing. I just keep on explaining you the basics, and basics are the one which will be asked in surgery. Surgery में वो हाका फाका syndrome जैसा कुछ भी नहीं आता. So again let us go to the next question. एक question था that what is this kit? So it's a very simple. There was a question on what is this kit and it was a peg. How to understand that this is a peg, not a central line catheter? Remember a peg. What is peg? Percutaneous endoscopic gastrostomy. Percutaneous endoscopic gastrostomy. बच्चे first of all, if you see this instrument, बाकी मुझे कुछ देखना ही नहीं है. If you see this instrument, this is an introducer with a, you can say with a inlet for 2 fingers, and you can pull the structures in. So बच्चे, we need to pull the tube in. So we have an introducer which will pass through the stomach, go through the abdominal wall, go outside, and then you will pull the tube in, and this is what is a peg, percutaneous endoscopic gastrostomy catheter. But it is not a pigtail catheter. I've already discussed each and everything in my classes. I've even shared a lot of videos how a pigtail catheter looks like. So this is how the pigtail is. The moment you pull out the stellate, it curves into a pigtail. This is not a central line. So let us, and of course it's not a you can say gastric tube. What is the indication? Yes, it is indicated when you have to start with supplemental nutrition. This is what is the simplest thing that you can understand. बच्चे, अगर किसी को आपसे कोई क्वेश्चन पूछना है in context with this, and let us understand that okay, the mood says there could be a question on supplemental nutrition. So let us understand those master concepts. All these PDFs will be attached to your class, post class, you can say video will be attached with this PDF. So from the app you can always download it and save it. Remember, whenever you want to start supplemental nutrition, this is what is very important. Let us quickly revise this, बहुत important है. And if the question is asked in context with this, ये question पूछा जा सकता है. Already covered this in rapid revision. So supplemental nutrition, if you have to start, you have to ask yourself, okay, should I start it? And if I want to start the supplemental nutrition, you again have to ask one more question, duration of lack of feed. बच्चे, बहुत important question है ये. Duration of lack of feed, if it is less than 7 days, in that case no need to start with the supplemental nutrition. If it is more than 7 days or more than equal to 7 days, then start supplemental nutrition. Now when we talk about supplemental nutrition, you know that we have to start with parenteral or enteral. So this is decided like enteral should be given until unless contraindicated. So very next thing is that is enteral nutrition contraindicated. You all know that it is contraindicated in 5-6 conditions. What are they? In case of perforation, in case of peritonitis, severe diarrhea, severe vomiting, severe malabsorption, and relatively contraindicated in case of the sepsis. Also, it is contraindicated in obstruction. So if it is contraindicated, yes, in that case you go for parenteral nutrition. If no, then you will have to go for the classical enteral nutrition. When you want to start with parenteral nutrition, so either you can give it by peripheral route or you can give it by the central route. The very next thing that you have to ask is how long do you want? So if you want a support for a longer time, then it's better to insert a central line and go for TPN. So duration of support, if less than equal to 1 week, in that case PPN, that is peripheral parenteral nutrition. More than 1 week, then you will have to start with TPN, total parenteral nutrition. When we talk about enteral nutrition, what to do? Again you have to ask yourself duration of support. Bachche, if you want a support for less than 4 weeks versus more than 4 weeks, if you want it for more than 4 weeks, you need a permanent, you can say, or a long lasting catheter, and that is where you will have feeding gastrostomy or feeding jejunostomy. This depends whether you are having a good gastric emptying or no. Less than 4 weeks, yes, you can go for RT feed, Ryle's tube feed or NJ feed. So this is the mood related topic, mood related question related topic. This is what is really very important. Next is, let us go to the next question. But you got a question. This is a very simple question. So this was a patient, 52-year-old female, presents with invasive ductal cancer with skin ulceration and inflammation. So ulceration of the skin, you know, it qualifies for T4B. An inflammatory sign will be always present at the ulcerative end. So don't think that it's a T4D also, because merely inflammatory signs are not a diagnostic of inflammatory carcinoma. Inflammatory carcinoma is actually the signs and symptoms of mastitis. Along with that, there's a criteria. The standard criteria is that more than 2/3 of the breast surface involved extensive involvement of the breast in a short span of time, not responding to the conventional antibiotics taken for the, you can say, for the patients of mastitis. So this is a patient with classical T4B cancer. If you see this was something, image was looking like this. बच्चे, बात आती कि क्या stage है. Remember, the stage 3 includes, encompasses all things. 3A, 3B, 3, we have 3A, 3B, 3C. Stage 4 is metastatic, so this cannot be answered. Remember, what is the best answer here? Either you can say stage 3, since we cannot comment on stage only by knowing the T, because we don't know the lymph node status, we don't know the you can say the metastasis status. So I would say that option C is far better than option A. This is what is the simplest way of understanding this. Let us go and you can say quickly revise. Bache, let us quickly revise this concept of, let us quickly revise the concept of this classification of CA breast. When we talk about CA breast, within 2 minutes we'll revise. Bache, CA breast is divided into early, into locally advanced, and into advanced. So when we talk about advanced, this is any T, this is any N, but M should be 1. When we talk about early, size should be less than equal to 5. So T1 to T2, N should be N0 to N1, and it should be M0. When we talk about the locally advanced, all of us know that T0, T4, N0, M0, T3, N1, M0, any T but N2 to N3 and M0. But last exam, last NEET-PG question, the question was, sir, who will take care of this T3, N0, M0? You have to understand, ये NEET-PG का question है. Now you can understand the mood, the trend matters. Trend matters. Last year ये question पूछा, उसी से related एक और question पूछा. So this is known as large inoperable CA breast. Now why this is large inoperable? Because of metastasis? No, because of the surgical inoperability. Now when we talk about surgical inoperability, what is the reason for this? You know that whenever we talk about CA breast, so if this is the tumor, we need to spare the space above also, below also, and then we need to remove the specimen and do a closure. But if the tumor is big, that is more than 5 centimeter, the skin flaps will not be possible. You will remove the tumor, but you will not be able to close this wound, and that is why the problem will arise. Let us move forward. So this is looking like a gemstone. Anyways, this is an image on X-ray crystallography. Try to understand this. This is what is simple. Now, 42-year-old male presents with recurrent UTI on urine analysis. It reveals alkaline pH. Following is the X-ray crystallography image. Students have shared me this image only. So, bache, the things which you can say resemble this, it could be resembling something like an envelope also, or it could be looking like a coffin lid also. So coffin lid versus envelope. This, if this was the image, because it looks more close to that. When we talk about the coffin lid versus envelope stones, where are we? You can say, where do we see them? Then if you see the history is suggestive of what? Infection. So infection associated, and this is more of alkaline infection associated. So first thing is, it cannot be a cystine stone, it cannot be uric acid stone, because both are seen at a pH of 5. तो अगर मुझे कुछ नहीं भी पता है कि कौन हो सकता है कौन नहीं हो सकता है, मैंने यहीं से काट दिया. बच्चे, then we have triple phosphate and oxalate stone. Hematuria can be seen with them, any of them, but hematuria is more common with the oxalate stone. Remember, we have you can say calcium So we have calcium oxalate monohydrate and calcium oxalate dihydrate. Dihydrate is envelope shape, but this is not associated with infection, but triple phosphate is associated with alkaline form of infection. So yes, this is the best answer of this. Is this clear to everyone? So you have to correlate the things. Anyways, there was a question again from the esophagus. Esophagus, this time we saw the maximum questions in GIT. Which of the following is or are atypical complications of GERD? So GERD, motility disorder, both have been covered. GERD ka complication, atypical complication, what do you mean by this? Let us understand. Now, when we talk about the typical complication, we know because it is because of the reflux. Now, sometimes the reflux might enter into the trachea also. And when it enters into the trachea, it will cause nagging cough. This is what is. Now, it will cause inflammation and inflammation related laryngitis, asthma, and in late stages it may cause interstitial lung disease or pulmonary fibrosis. So all four of them are, you can say, associated with this. I hope all of you know that this is the mood, and if it is a mood, what could be the mood related questions? Let us understand this. Let us understand. This is what is very important for you to understand. Okay. So when we talk about any question which can be related, if I have to ask, someone says, okay sir, ask one question from GERD related to its complication, something related to its complication. So when we talk about GERD and when we talk about complication, so we have typical complications and we have atypical complications. Atypical we have discussed, and the typical complication that we have something which is known as Barrett's esophagus. This is important. And then we have CA esophagus, and you know that adeno CA is what is seen. Now when we see the mood, why I am telling you I am talking about mood, because अगर आप last year का NEET-PG का paper देखो, so you had a question on Barrett's esophagus. I think it was NEET or INI-CET. Barrett's का question था. So again the trend is continued. So when we talk about this Barrett's esophagus, and if you ask me, sir, make one question on Barrett's esophagus, I hope you know that what is defined as Barrett's esophagus. The squamo-columnar junction, this migrates up. So there is upward migration of squamo-columnar junction, and along with that we have intestinal metaplasia. Students, even this is also not important. The most important thing is on HPE you get to see what cells? Goblet cells. This is what is important, very, very, very important. And you know that, yeah, I think is the question atypical? No, the question was on atypical. This is this is what I have gathered from the, you can say, from the recalls. So they have asked about the atypical complications of the GERD. Now when we talk about the Barrett's, what is the short segment Barrett? When we talk about short segment, this is less than 3 centimeter. When we talk about long segment Barrett's, this is more than 3 centimeter. When we talk about ultra short Barrett's esophagus, this is defined as less than 1 centimeter. This is what is a Barrett's esophagus. Now अगर हम Barrett's esophagus के types की बात करें, and based on the types we can quickly revise their management also. It is unknown for atypia. There is Barrett's esophagus without atypia, point number 1. Point number 1 is without atypia. The second is Barrett's esophagus unknown for atypia, Then we have the dysplasias. It could be the low grade dysplasia and it could be high grade dysplasia. But I have already told you that the Barrett's esophagus with atypia, Barrett's esophagus without atypia, I have written with atypia, sorry, without atypia, and Barrett's esophagus unknown for atypia, you will have to go for conservative management with anti-reflux medication. This is very important. Anti-reflux medication देनी ही पड़ेगी, and along with that annual upper GI endoscopy follow up. This is what is very important. 2 बार 3 बार पूछा गया हुआ है. If you get a question on low grade dysplasia, what is the management? Same, anti-reflux therapy has to be given. And when we talk about anti-reflux therapy, along with that 6 monthly upper GI endoscopy follow up. Can you see the difference? Now when we talk about high grade dysplasia, you have to start with anti-reflux therapy. So moral of the story is we will start with anti-reflux therapy, and along with that reassess after 3 months. Now this is what is very important. Why? Because agar Barrett's stays as Barrett's for a long time, so this is what is known as persistent high grade dysplasia. Now this is a candidate for intervention. Now when we talk about intervention, you can go for radio frequency ablation, or you can go for endoscopic mucosal resection, EMR. Is that clear? So अगर वो mood related फिर से question आया, so कुछ ना कुछ तो अलग आएगा ही, and that is why my kids have anticipated कि okay, so they know that this would be the questions. बच्चे, a very easy straightforward question. Again you will say mood. बच्चे इससे पहले last NEET INI-CET there was a question. It was there in FMG. क्वेश्चन हर्निया पे आता ही आता है. So which is the most common hernia in females or in males? In both of them, this is indirect inguinal hernia. So indirect inguinal hernias, this is the answer. बच्चे, if the question is asked, because last year they have asked the question on EHS classification question आया था, and when you talk about EHS classification, you know, European Hernia Society has been the oldest in hernia management, and they are the one who have actually decided a lot of protocols. So you know, E stands for etiology. What could be etiology? It is primary, that is not associated since birth, so you can write P. It could be congenital, that is by birth, or students it could be recurrent, this is what is R. So this is the simple R. Then we have hernia defect. When we talk about hernia defect, what are the things that we have? Up to 1.5 centimeter, up to 1.5 centimeter you will say 1F. More than 1.5 up to 3 centimeter you will write 2F, and more than 3 centimeter you will write 3F. This is what is very important. अगर आप exam, last exam को देखो, there was a question. And then when we talk about the site, you know that if it is medial, then that is actually for the direct hernias, direct inguinal hernia. Then if it is lateral, lateral with respect to the inferior epigastric, so that is indirect hernias, and it could be femoral. So if it is, so it could be M, it could be L, if it could be F. So this is how we decide what is what. So question अगर आता है दोबारा, yes, this would be the most probable question that would be asked. Okay, student, let us move forward and discuss one more question. Now, what is the significance of ER positive with context to CA breast? बच्चे, try to understand that whenever we talk about CA breast, we need to study the molecular resemblance of the tumor, and that is why we have 4 standard molecules: ER, PR, HER2/neu, ER, PR, HER2/neu, and Ki67. So they tell about the tumor and its significance. Now here, बच्चे, they don't have any diagnostic, they don't have any therapeutic. So they are a surrogate molecular marker. This is absolutely true. And since they are a molecular marker, their positivity, their negativity will give you a chance to add, or you can say refrain from using a hormone therapy. So remember, if you see the option C is better than option B, why? Yes, it could be a prognostic factor, but not in a normal CA breast. In case of metastatic CA breast, where all the other factors have been nullified, then it is a significant prognostic factor. So yes, option C is also right, option B is also right. If I have to choose, I will choose option C. It's a surrogate molecular marker, and it is an indirect prognostic marker. Remember, बच्चे, exams में you always have questions where 2 options can be right and you have to choose the best. So this is the answer that I would have chosen, because yes, it's a surrogate molecular marker for. Next is again my favorite topic, cholangiocyte. You get a lot of questions. Bachche, you have to understand that primary sclerosing cholangitis is the most important thing. Then we have the chemicals, and in chemicals you have thorotrast, you can say aromatic hydrocarbons. So aromatic hydrocarbons, we have thorotrast, this is important. Then students, there is something which is known as hepatolithiasis. So hepatolithiasis means stone in the hepatic duct. Yes, they cause cholangiocyte. बच्चे, Carolis, yes, choledochal cyst. Choledochal cyst is an important risk factor. Then there is something which is known as von Meyenberg disease. So when we talk about von Meyenberg disease, or you can say multiple biliary hematomas, multiple biliary hematomas, they are also a risk factor for this. Remember, yes, liver fluke, Opisthorchis sinensis, or Escherichiasis, they are all risk factor for this. But hepatitis is a risk factor for HCC, not a risk factor for cholangiocyte. बड़ा easy सा question था. Next is, let us understand one more question. 54-year-old presents with lower lip weakness post recent parotid gland surgery. You know that parotid gland, through the parotid gland, we have a fasciovenous plane of Patty. What is this fasciovenous plane of Patty? I hope all of you should be knowing this. So when we talk about, this is the deep lobe, this is the superficial lobe, and through this we have the retromandibular vein, and just above this we have the facial nerve and its branches. So you know the trunks, upper, lower, and then we have the external carotid artery below this. So lot of complications can arise, but the most important is maybe because of the facial nerve injury. Now the patient is having lower lip weakness, which is due to the mandibular division of the facial nerve. So let us see what are the answers in this case. Injury to greater auricular nerve, बच्चे, this will cause loss of you can say sensation over the skin of parotid. You must have seen that movie Dabang, प्यार से डर नहीं लगता, थप्पड़ से लगता है, या थप्पड़ से नहीं प्यार से लगता है. So here the patient will also not feel that थप्पड़. So इसको भी थप्पड़ से डर नहीं लगता है. This is why, because of the injury to greater auricular nerve. Then cervical branch of facial nerve, no. Temporal branch, no. It is the mandibular branch which is going to cause this. So injury to main facial trunk will involve the denervation of all of them, and that is what. Go and check my YouTube video on facial nerve injury and all the things that we have. I have demonstrated it many a times. So the answer for this is A. It is due to the, if this is the option, and if they have asked about mandibular branch, it should be the answer in that case. Now lesions. Lesion with midline swelling in the neck with a nodule containing amyloid stroma. What is the possible origin of this lesion? Bachche, a thyroid swelling, and when we talk about thyroid swelling which contains amyloid, containing amyloid, what is the most important thing? What is the most important tumor? Now we are talking about MTC. What is MTC? We all know, medullary thyroid cancer. Again you see the mood. Recently there was a question in INI-CET also, there was a question last year. MTC पे question आया, इस बार उसी question से थोड़ा बहुत वो पलट के थोड़ा they have asked. So these are the tumors of what? These are the tumors of parafollicular cells. Let us quickly understand this. And अगर अब दोबारा question आया MTC पे, so let us have 2-3 important concepts about that also. So when we talk about MTC, medullary thyroid cancer, 2-3 things we need to understand. That it is associated with RET proto-oncogene mutation. It's a tumor where you have calcitonin to be increased. And why? Because it's a tumor of parafollicular cells. This is what is very, very, very important. Then you know there is increase in CEA because it's a carcinoma, and paraneoplastic syndromes are also there, because of which you have increase in histamine. So you know that we have pruritus, all those vasomotor symptoms. You have increase in serotonin, so you have diarrhea, and then you have increase in ACTH, so you have the Cushing's-like syndrome. Remember, on HPE you get to see amyloid stroma. ये बहुत पुराना question है. Along with that, there is also one inclusion body which people call as cell ball inclusion bodies. So cell ball inclusion bodies can be a part of this. Remember, I am not here to discuss this. अगर मुझे आपसे कोई question पूछना होगा, so I will always ask about the management. बच्चे, MTC is an aggressive tumor which has an extensive and aggressive spread by the lymphatic routes. So whenever we are managing any carcinoma, the rule is that throw that tumor outside the body. If you think it's a cancer, the place should be outside the body. So when we talk about the management of MTC, remember what is the rule? Total thyroidectomy has to be done, and along with that prophylactic neck dissection. Now when we talk about prophylactic neck dissection, what do you mean by this? The rule is always screen the next landing zone. ये सबसे important चीज़ है. Many of you mug this up with the concept of remain one step ahead. This is what is very, very, very important. Why not option as no, amyloidosis is not seen in thyroid very often. Okay, so I don't think that option would have been amyloidosis, but the students have discussed that. So why a thyroid swelling will present to you with amyloid stroma? Remember, a nodule. I think the question also described about the nodule, the tumor. So a tumor with amyloid stroma, this is of MTC, module, you can say. Thyroid will never have a nodule arising because of amyloidosis. Amyloidosis is possible. Amu, but a nodule which on FNA or which on biopsy revealed amyloidosis, this is seldom due to amyloidosis, it is due to amyloidosis associated with MTC. So it is because of the tumor that the amyloidosis has started, not you can say isolated event of amyloidosis. Anyways, let us understand. So case number 1, what is the case number 1? When you have the tumor in the, you can say, gland. So at least you would have done what? Total thyroidectomy, ye to karoge hi karoge, and along with that, if you have to do something, yes, you will screen the next landing zone, and therefore you will go for prophylactic central neck dissection. This is what is very important. So what is the management? Total thyroidectomy plus prophylactic central neck dissection. Case number 2. When we talk about case number 2, what is that? Imagine there is a tumor with few central neck lymph nodes also. So अगर आपको कुछ भी tumor remove करना है तो every evidence, so you would have gone for total in this case, and along with that you would also have gone for central neck dissection. If the tumor has to move from this side, it would move in this place. So therefore prophylactic ipsilateral MRND would be done in this. So what would be the answer? Total thyroidectomy plus central neck dissection plus prophylactic. So when we talk about the case 3, बच्चे अगर इसमें क्वेश्चन आता है जिसमें you have the lymph nodes in the lateral part of the neck, so at least by rule जो भी evidence of tumor है you will have to remove. So yes, you will have to go for total thyroidectomy along with that central neck dissection. And when we talk about this scenario, you will go for bilateral MRND. This is the simplest way of management. Let us move and go to the next question. A patient, a 22-year-old alcoholic patient, presents with severe hematemesis. So patient with upper GI bleed due to portal hypertension. The USG shows distended portal vein with you can say with coarse echo texture, hyperechoic and coarse echo texture in the liver. What is the next appropriate management? Bachche, you are dealing with upper GI bleed. This is what is really important. And this is associated with portal hypertension. What is the protocol of this? This is what is really important. The first is you need to secure ABC. This is the first thing that you will do. कुछ भी नहीं करोगे. You will go for secure ABC, and after this, the next thing is you need to control the blood pressure. Control the blood pressure. Along with that, you need to stabilize the patient. So control the blood pressure, and resuscitation of the patient is really very, very important. Now when we talk about the controlling of the blood pressure, resuscitation, and along with that you will start with injection octreotide or somatostatin analogues, or you can go for terlipressin, all those things. But remember, if the bleeding stops, then only, so post 12 to 24 hours, within 12 to 24 hours, now you will go for upper GI endoscopy. बच्चे immediate upper GI endoscopy नहीं करते, early intervention is important. So within 12 to 24 hours, but before that you need to stabilize. Now there could be two options. It could be, now this depends what is the cause. पहले अभी हम इसका आंसर डिसाइड कर लेते हैं. ब्रॉड स्पेक्ट्रम एंटीबायोटिक्स तो दोगे, but that is not the first line priority. Yes, it is given. Broad spectrum antibiotics are given. Perform liver biopsy, not at all. Urgent endoscopy with varicose ligation, not at all. I will tell you. Start with fluids and electrolyte replacement. This is the answer. Let me tell you how do we manage this. ये बहुत important सी चीज़ है. This is very, very, very important. So let us see this. Okay. Now whenever we have a patient of upper GI bleed and the patient with portal hypertension, the next is you will try to control bleed. Now once you control the bleed, or you can say you have done this, all those things like secure ABC, and then start octreotide, and once you have done this, the next thing is okay, plan upper GI endoscopy. But when you plan upper GI endoscopy, the very next thing is, where is the location? So ये जो question है ना कि we will do a band ligation, yes or no? So question told severe vomiting, not hematemesis. Okay, acha, severe vomiting was there. I don't know the question. You can text me the question, or if you have, you can type it here only. So if it is a question associated with this is what is I am telling. Since I have not given the exam, it is all recall based. Niharika, you can type this question in the comment section. I'll just tell you the answer based on that also. Next is location. Bachche, the location could be the GE junction. It could be the GE junction. It could be the lower esophagus, or it could be the isolated gastric varices type 1. ये सब important है क्योंकि अगर GE junction, lower esophagus और isolated gastric varices है, then it is different management. If it is isolated gastric type 2 or if it is others, the management shall be different. So if the IGV2 or others are there, the next thing is you have to plan for TIPS. I hope you know transjugular intrahepatic portosystemic shunt or BRTO, retrograde balloon transvenous, you can say occlusion. This is what is the management if the patient is having isolated gastric varices. Bachche, if it is a GE junction, if it is a varices or if it is a lower esophageal, you can say bleeders, you have to understand, is it bleeding? Is it bleeding? So bleeding persists, you have to understand this, or bleeding stops. If the bleeding stops, you have gone for endoscopy. If the bleeding stops, in that case, continue octreotide for 3 to 4 days, and along with that antibiotics for 10 to 14 days. At least ये तो करना ही करना है. And the conventional, yeah. So yes sir, patient was alcoholic, binge of alcohol last 5 days. Remember, being alcoholic doesn't mean it's a portal hypertension. If it is a portal hypertension, the scenario will be different. Alcoholic patients can have gastritis also. So it could be a gastric ulcer. So can you just elaborate the options, whether the options were related to portal hypertension or no? So one option was please, you can give me the entire question. I'll just comment on that scenario also. So chlordiazepoxide is not the ideal management here. Now, next is if the bleeding continues. Bachche, if the bleeding continues, you have options. What are they? The first is EVL, endoscopic variceal ligation, or the sclerotherapy, or the balloon tamponade. If this persists beyond this, so you have done sclerotherapy, if it persists, in that case, you can plan the, you can say balloon tamponade. I hope you know about that. Balloon tamponade is one option. If balloon tamponade fails, balloon tamponades, or you can plan for TIPS, or you can plan for shunt. These are the options that we have, or you can plan for devascularization surgeries. So these are the options that we have. When you talk about devascularization surgery, go and check my notes. I have described about the concept of the Sugiura surgeries, and the one more is that is the splenoneumopexy also. Recently that has also been added. Anyways, so Niharika, you can just text me the question along with the options. I'll revert back to that. Again, there was a question on Wilms tumor. Not true about Wilms tumor. When we talk about not true about Wilms tumor, it presents with an abdominal mass. Yes, it presents. It is seen in both male and female. Yes, you know the classical presentation is a mother noticing an abdominal bulge while bathing the baby or changing the clothes. Lung metastasis is a late and rare presentation. But say 80% survival after chemo and radio. Students, it is the surgery and the chemo. This is what is very important. So chemo plus surgery. It is important. It is not surgery alone. It is not chemo alone. So chemo with surgery. Yes, you can have different options of NEET. And what is the surgery that we have? Radical nephrouretrectomy. Nephrouretrectomy. This is what. But say, what is the difference between radical nephrectomy and nephrouretrectomy? Understand, in radical nephrectomy, you will remove the ureter up to the pelvis. So at the level of where the pelvis is starting, you will remove. When you talk about nephrouretrectomy, right up to the insertion at the level of bladder, you will remove the ureter. So this is what is the ideal management. अब आप कहोगे रेफरेंस क्या है सर, हमने तो सब जगह यही पढ़ा है कि इट इज़ रेडिकल नेफ्रेक्टमी. बच्चे कैलालिस क्लिंग इज़ द बेस्ट बुक फॉर पीडियाट्रिक यूरोलॉजी, उसको खोलो, वहाँ पढ़ो, रेफरेंस क्लियर लिखा है. रेडिकल यूरेट्रेक्टमी इज़ द आइडियल सर्जरी. लेकिन अगर वो नहीं दिया है आपके लेवल पे, रेडिकल नेफ्रेक्टमी भी एक्सेप्टेड है. दिस इज व्हाट इज नाउ नॉट अ पार्ट ऑफ प्राइमरी सर्वे. पहली बात है भैया, प्राइमरी सर्वे इज द सर्वे डन बेड साइड. सो दिस इज वेरी इंपॉर्टेंट. इट इज डन बेड साइड and it is done with an intention and aim to rule out immediate life threatening you can say injury and save the life of the patient. So will you do x-ray chest? Yes, bedside x-ray has to be done to see whether it's a pneumo-hemo or whether there are fractures etc. Intercostal drain insertion, tube thoracostomy has to be inserted in certain cases of pneumohemothorax. Intubation if the patient is going or showing you progressive desaturation. बच्चे NC-CT, CT cannot be done bedside, so you will not consider about this. So बच्चे जो भी करना है bedside करना है. NC-CT is not a part of this. This is what is very 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 important. बच्चे वही फिर से वही understanding the mood. So when we talk about the mood, we have primary survey. Everyone knows about that primary survey. And then once the patient is hemodynamically stable, we do what survey, students? We do secondary survey. And when you have done secondary survey, 24 hours, 48 hours and 72 hours, you will also do a survey which is known as tertiary survey. So tertiary survey is a modified version of secondary survey. It's a replica, but yes, done at 24, 48, 72 hours to modify the outcome of your interventions. So you have done some intervention, you need to you can say have a look on these patients for certain delayed complications which might be arise. So अगर कोई पूछता है कि tertiary survey बोल के कुछ होता है, yes, it is there. Is that clear or no? Next is hoarseness of voice seen post thyroid surgery. बच्चे thyroid surgery, hoarseness of voice is due to recurrent laryngeal nerve injury. This is what is important. So strap muscle dissection, whenever we talk about strap muscle dissection, Bier's triangle dissection, tubercle of Zucker-Kandel and superior thyroid vessel ligation. Now this is what is very important. Now when we talk about the strap muscles, they are important landmark, and at the point when they are entering, so there is a cricothyroid, you can say there are a lot of triangles. So this is the carotid. When we talk about, this is the carotid, this is carotid, and this is the inferior thyroid pedicle which is running. So the classical recurrent laryngeal nerve, along with this, you can say the inferior thyroid pedicle forms a lot of, you can say, triangular relations. One of them is a Bier's triangle. We have lot of triangles. So we have, if you go through my lectures, I have discussed around 7-8 triangles. I am not going to discuss here, but yes, the Bier's triangle is a triangle where if you dissect, the recurrent laryngeal nerve injury can be seen. Tubercle of the Zucker-Kandel is the most posterolateral part, where if you don't locate the recurrent laryngeal nerve, means it is not there or you have already injured. So यहाँ पर, but superior thyroid pedicle is associated with the extrinsic, you can say, laryngeal nerve, and it is not associated with this recurrent laryngeal nerve injury. So it will not be seen in this case. Yes or no? Let us move forward. Again, falls with respect to Crohn's. बच्चे Crohn's versus ulcerative colitis, it is very simple. Ulcerative colitis, remember, ऊपर. So ulcerative colitis involves the mucosa. Crohn's is the complete involvement. One very important thing. Where do you see? So if you talk about the you can say the lesion. So lesion is complete transmural versus in ulcerative colitis it is the mucosal. Granulomas किस में मिलेंगे? The granulomas will be seen in the Crohn's. This is. Then when we talk about the location, where are they found? Remember, it is found in the large intestine only. It can be seen anywhere. This is important. Even in the large, in the small, कहीं भी हो सकता है Crohn's. बच्चे, what about the rectum? Rectum is always involved. Remember, it may be, it may not be involved. What about perineum? Now this is what is important. Perineum is spared here, but it is a very common lesion. So rectum छूट जाता है, but perineal lesions are very important. Which variety is associated with fistula? it is seen here, not here. Strictures, it is very common here. It may be, it may not be. Perforations, yes, it is seen here. So बच्चे, अच्छा, malignancy. Now again, if we compare about malignancy, a very high risk here. Here you have a low risk. So with comparison to ulcerative colitis, what is true about this Crohn's? No perianal lesions, this is false. Contiguous lesions, no, they are associated with cobblestone or snake skin appearance. So that is, we have discontinuous skip lesions. So skip lesions are there. So this point is also false. Less risk of colon cancer, yes. Ab hematochezia. Now you must be thinking hematochezia is nothing but stool with blood. Bache, instead of this, if we see, what do we get to see in Crohn's? We get to see diarrhea. This is what is very, very, very important. Plus rectal bleeding. So diarrhea plus rectal bleeding, you can say it could be hematochezia, but not, it could be rectorrhagia. This term is rectorrhagia, independent bleeding. So rectorrhagia, not hematochezia. Hematochezia means streaks of blood on the well-formed stool. So I would say option B is far better than option A in this case. So this was about this INI-CET. I hope you enjoyed this paper and you developed some concepts. Why I discuss a lot of things? Because I wanted to tell you that the topics, the concepts are repeated. The questions are not repeated, the topics are repeated. So keep on learning with Surgery Dada and don't panic about the exam. The exam is gone. Jo ho gaya so ho gaya. Let us now concentrate on the upcoming NEET-PG exam. So till then, bye-bye.